Good morning, everyone. We're just going to give it another minute or two to see if anybody else joins us. I'm going to put in a post a pre-test. If you have a chance, if you could go ahead and maybe take a few minutes to start filling out that pre-test while we're just giving it a couple more minutes. Summer, if it's okay with you, we'll start maybe at 10:05. We'll give it another minute for more people to join.
Sounds good.
Okay. Okay, it is 10:05. Again, thank you for joining us for our webinar. We appreciate everyone taking a part to recognize fetal alcohol spectrum disorder. Today is FASD Awareness Day. So we appreciate our Children's Service Center, Summer and Jessica, coming to help do a presentation on us as the experts on FASD over in our area. I'm going to go ahead and introduce everyone. As you can see, my name is Jennifer Jones. I'm the CAS coordinator here from CMSU. And I also have Allison Wilson, who is our prevention specialist from CMSU. What we're going to do is pass it off to our Children's Service Center experts in the FASD. We have Summer, who is the Vice President of Programs and the Director of the FASD program, the initiative that came over this way. And we also have Jessica, who is the Family Navigator and the Family Navigator expert in the FASD that works with programs out in Luzerne County. So I'm going to go ahead and pass it over to you, Summer, if you kind of wanted to give any more information on that before we start the program.
So like Jen said, my name is Summer.
I'm Jessica.
So Jessica and I have really been working very diligently since about 2021 to really spread awareness and education for fetal alcohol spectrum disorder. So we're always very excited and honored when we're asked to give a presentation. So we can go ahead and get started just because we have a lot of information to go over in a short amount of time. So I'm going to share my screen. We're going to start with a video.
Humanity is at a crossroads with one of the biggest, preventable, global public health crises that we have ever faced. Here in the United States, we call it the invisible disability because it's hidden in plain sight. But it's time we lift the mask. What is FASD? FASD stands for Fetal Alcohol Spectrum Disorder. This happens when a fetus is exposed to alcohol while in the womb, causing permanent brain damage to the unborn child. Modest estimations from experts place 1 in 20 people with an FASD. This means
All of us know someone with an FASD. There are sisters, our brothers, our neighbors, our nieces, our cousins, our parents. FASD impacts us all.
There's a common misconception out there that early alcohol exposure in pregnancy isn't harmful. You hear people saying, drink till it's pink, meaning it's okay to drink until you know you're pregnant. Unfortunately, it's not true. In fact, some of the most fundamental development occurs in that early stage, that time before a woman's even capable of having a positive pregnancy test.
About 40 to 50% of pregnancies are unplanned. So you know that there's a tremendous amount of alcohol that it can be consumed before someone even has a confirmed pregnancy.
Wasn't aware. I was pregnant. You know, we talk about unplanned pregnancies in the FASD field. I had an unplanned pregnancy.
We've got doctors still telling us it's okay to drink alcohol. My doctor, I mean, I had 2 pregnancies. My doctor didn't ask me a thing about alcohol.
I think the biggest issue there is we need to have screening in place, but to do that, we need to meet people where they're at, and we need to have providers that are willing to ask the hard questions, because there is such a stigma still around prenatal alcohol exposure.
Both the amount of alcohol and timing of exposure can determine the severity of an FASD in the affected baby. This is because alcohol is considered the most damaging substance to a developing fetus, more damaging than any other substance.
And I have never met a mother that had any intention of hurting their baby.
I would say no safe amount of alcohol ever during pregnancy or during breastfeeding.
After birth, a baby with an FASD is faced with lifelong adversity due to the multitude of mental and physical health issues that result from alcohol exposure. It is referred to as a lifelong sentence because individuals with an FASD can never outgrow or cure this disability.
These individuals do not have to be born with the disabilities that they live with, and it's permanent disabilities. It is lifelong.
For most children with an FASD, early care and interventions are next to impossible. This is because diagnosing FASD is complex and inaccessible to most.
How can we get this awareness out to not just women of childbearing ages, but to the community at large, to employers, to the liquor outlets, to restaurants, to grandparents, whoever will listen to it, so there is an understanding.
I came to a website on fetal alcohol spectrum disorders, and I had no idea it was a spectrum disorder. And as I'm reading that and I'm looking at and I'm seeing that you don't have to have the facial features, and I'm looking at the list of symptoms, and she has almost every one of them. I guarantee you that you have friends and family in your life who are on the fetal alcohol spectrum and maybe are undiagnosed or misdiagnosed with other things.
I'll hear people say, I drank and my child's fine. And we know that there are so many dynamics that play into an FASD, and it's not just the alcohol. But when you think of the 450 conditions under the FASD umbrella, it's like, are you sure your child's okay?
Fetal alcohol spectrum disorders are not just diseases of, if you will, underrepresented minorities, Native Americans, and those with low socioeconomic status. That is one of the biggest misconceptions in regards to it. Fetal alcohol spectrum disorder, similar to other, if you will, conditions, affects the entire population, including the majority.
Even for children who receive an accurate diagnosis early on, there are little to no resources or special training available within our public education system.
I guess people just didn't understand it, and they didn't really want to try and understand it, which I think is a huge thing, is just wanting to learn about the struggles that your students face. And I think that that's hard when you have 500, 600 students in a school.
%60 of people with FASDs have issues, have trouble with the law at some point. Out of that group, 35% end up going to jail. And if you look at the reasons for that, you can understand some of the symptoms are like sensory issues, having difficulty with executive functioning, understanding consequences.
I got that a lot because I thought I was a bad kid, but I was just hyperactive and I didn't know how to express myself. I still don't, but like, we're not bad kids. You just have to be patient with us.
The lack of awareness, training, and resources within our education system fails these children, which can lead to substance use problems, mental health challenges, and is often a gateway into our legal system.
I don't want to suggest that your children should be immune from prosecution. That's not the case at all, or immune from arrest. If they get in trouble, they have to face consequences, but the consequences should not be the same as a person who has no cognitive impairment.
There is no current statistical data on U.S. prison numbers and FASD. However, in Canada, 31.2% of incarcerated adults have FASD. If we conservatively applied that same number to the U.S. prison population, that would mean the U.S. government spends an estimated $22.2 billion per year on imprisoning individuals who have an FASD. FASD is unseen and unrecognized by the majority of our society. This truth carries a profound economic impact.
I think that we can demonstrate that through structure and through sentencing alternatives, we can save taxpayers money by not incarcerating this population, but by giving them services and making sure that they have structure in their lives. A job, a roof over their heads, and something to focus on outside of your employment. That's something that everyone with FASD needs.
For the first time in a long time, this is my home. When I was at my other group home, I didn't call it home because I didn't want to go back. But now, this house, I know I belong here now. It's one of the best places I've ever been.
I just wish this wasn't the only one. I'd like to encourage more people to start, like have a group home for people with autism only, have a group home for people with Down syndrome only, dementia, you name it. Because there are times where if you take all the disabilities and put them in one house, it's hard to communicate with each other.
Currently, there are very few resources for families and individuals with FASD at the federal or state levels. Without the needed supports, individuals with FASD show up with astounding prevalence in our legal systems, sex trafficking rings, and homelessness. Because of the difficulties related to diagnosing, experts all agree the prevalence of this disorder is profoundly larger than current statistical data would show.
In 2010, the Department of Human Services issued a report really recognizing FASD as a crisis in our state. More than 9,000 children are born every year in Illinois that are FASD, and that is a low number because we know that based on a difficulty in making a diagnosis, that number has to be exponentially higher. I think it's probably 30,000, 40,000 children born every year in Illinois with FASD.
FASD isn't only difficult for the individual, but the challenges associated are life-altering for their family, guardians, and caretakers.
It went to the point where me and my mom we could barely stand to be in the same room with each other without her wondering what it is that I'm doing and if I'm doing the right thing. And we would just constantly get into fights, and sometimes I still beat myself up over it.
I can't do this anymore. I don't know what we're gonna do. I don't know where we're gonna go. I don't know what we're gonna do. And when I'm like that, she's lost because I'm hurt. I'm hurt stone, I'm hurt tether, to what do I need? Mom will help. And I always have, but I felt like I couldn't.
It's hard too, as a mother, feeling that you're not doing what it was needed to be doing for your, are you good enough? Have you done what you can?
We need constant support and emotional support and sometimes physical support. But if you see a kid with disabilities, you can't just be like, oh, there's that kid. There's that freak. There's that mistake.
The crux of this public health crisis is that it is preventable.
It's a real disease that is preventable.
FASD is preventable.
FASD is preventable.
It is largely preventable.
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 This is the crossroads we find ourselves at.
I think if we start to focus on the pregnant woman and the pregnancy as being this precious, special event process, then I think we will start to apply the proper value to what would make that special process safe and protected and to have the best and healthiest outcome.
Here in the US, we deserve to know the truth around alcohol and pregnancy. Once we have that truth, it will take all of us to support those living with FASD and to support women in pregnancy.
FASD is an unavoidable issue. It's inescapable. Its effects are far-reaching through our American landscape. There are millions of individuals and families struggling in the US from this preventable disability. And collectively, we have overlooked this issue for far too long. Resources are needed for those living with FASD. They deserve a better life. And those who have no voice need our protection, our future unborn children. Awareness of FASD is the only route to end the struggle. Every person can help this cause by knowing what FASD is and who it impacts. And that's all of us.
Every state, every town, every place in the world needs to understand that FASD doesn't just affect the people with it or their parents or whatever. People with disabilities can do great things. We just need to be shown that we do matter. We can do all these things.
Always remember the lasting impression you can make on me and people like me. And we can leave with you. Thank you for leading.
It's time to act. Join the movement at the FASD Project and be a part of the awareness and change that is needed.
All right, we're going to get into our PowerPoint now.
So I'd like to start off with a quote from a parent who has a child with an FASD. Having a diagnosis enabled us to see our son differently, to parent differently, to admire him for his resilience, tenacity, perseverance, and motivation to continue trying, despite the daily hurdles and challenges he faced.
So like I'd explained at the beginning, Jessica and I have been working on this FASD pilot project since roughly 2021. We have been working with Luzerne County System of Care and FASD Task Force for the state of Pennsylvania to really bring awareness to this area, this region, and to provide services for individuals that have been impacted with FASD. So we screen all of our individuals that come to Children's Service Center, doesn't matter what department they're entering in at intake. There's a FASD screening. If that screen is positive, then they have a life history assessment done by their clinician. If they are positive for a probable FASD, because FASD is not a diagnostic term in United States at this time, but if they have a probable FASD, then we do refer them to Jessica or Edwin. There are FASD family navigators for continued education and support. So the video that we just watched had a lot of statistics, but there's a couple that we really like to point out. There are statistics that FASD affects 1 in 20 children, which is pretty astounding. With behavioral health providers, that 1 in the 20 children are the individuals that are typically seeking out behavioral health services. So when the work that we do daily, we are seeing a lot more individuals impacted with FASD than we're aware of. FASD is also more common than autism. It's the leading cause of intellectual disabilities in the United States, but most states do not recognize FASD as an intellectual disability.
So we know fetal alcohol spectrum disorder is an umbrella term. It encompasses a range of conditions that someone may have as a result of prenatal alcohol exposure. It is lifelong, brain-based, and often a hidden disability. And like Summer had said earlier, FASD is not a diagnostic term. It's also very similar to the autism spectrum. So within that spectrum, there are actual diagnoses. If we look at the chart, we will see the medical terms. Fetal alcohol syndrome is what everyone is more familiar with. This is where the individual may have those facial features, those characteristics with the smaller eyes, smooth philtrum, smaller nose, and even smaller head circumference. Partial fetal alcohol syndrome is an individual who may have some, but not the full effects of fetal alcohol syndrome. Alcohol-related birth defects, this is malformations and deformations of organs and any one of the major body systems. Mental behavioral terms, this is where we're looking at more of the hidden disabilities because there are no actual physical characteristics, nothing physical that we can see on the individual. Alcohol neurodevelopmental disorder is where we're looking at the cognitive and intellectual disabilities. Neurodevelopmental disorder associated with prenatal alcohol exposure is a newer diagnostic term in the DSM-5. Here we're looking for impairments within 3 areas: self-regulation, adaptive functioning, and cognitive functioning as well.
So alcohol is a teratogen, meaning it crosses through the placenta and passes through the maternal blood supply. So alcohol is the most dangerous drug. It's more damaging to a fetus than heroin, methamphetamine, marijuana, because it is a teratogen. So when a pregnant person drinks alcohol, it does pass through the placenta to the maternal blood supply. The fetus then excretes the alcohol back into the amniotic fluid. The fetus is swallowing that amniotic fluid repetitively, so the alcohol is being reabsorbed. And the fetus does not yet have a liver yet to process the alcohol. So as an individual who is consuming the alcohol, we might feel the effects of that alcohol for a couple hours, maybe in the morning, wake up, feel a little dehydrated, and then it passes. That fetus can feel the effects of alcohol for a much longer time frame, sometimes up to 72 hours. So the damage can be much more extensive.
If we look at the developmental stages, alcohol can affect any area during development. If we look at the first trimester, here we're looking at alcohol deforming cells. They are killing cells off or causing cells to kind of miss their target. We're also looking at the facial features, and this is why there is such a misconception that all individuals that have an FASD have those specific facial features. It is only within the first trimester, specifically days 17 through 21, is when the face is beginning to develop. So it is only at that point alcohol being consumed can cause those facial features. Within the second trimester, we're also looking at permanent brain dysfunction, permanent brain damage, damage to the brain structure as well as cells. But we're also looking at cognitive and intellectual disabilities. The third trimester is very crucial because the hippocampus can be greatly affected, which is going to cause the impairments within memory and learning. So we know that there are 10 domains. We're going to look at specifically these 2 areas of the brain that are affected by alcohol. So if we look at the cerebellum would be affected and impaired within cognitive learning. The corpus callosum is kind of like that communicator which connects left and right hemisphere. So an impairment within either one of those areas, we're going to see issues with memory, executive functioning, and an individual may be able to hear and understand what you're saying, but may not be able to do it. The corpus callosum in the second image is the affected brain. There you can see that the brain is much smaller and the corpus callosum is thinner. In some individuals, it is either underdeveloped or it's almost absent, like non-existent.
Okay.
So some of the symptoms we refer to them as symptoms with an individual with an FASD. We look at executive functioning, working memory. Here, the individual has an impairment with being able to store and retain information. So these individuals are going to be very forgetful, disorganized, or you're going to constantly be repeating the same thing over and over to them because it is their short-term memory that's affected. So for an example, coming into school on Monday, explaining what the day routine is or the morning routine, and then by Tuesday, they may remember, but by Wednesday, they don't remember so much. And then by Thursday and Friday, they've completely forgotten. It is being able to store what they are able to process and understand, and then be able to go back to it. So if we're giving an individual a lot of direction, come home, hang up your school bag, hand me your work folder, grab a snack and sit down and do your homework. That's way too many directions, way too many tasks, and too much information for an individual to be able to process, understand, store, and as trying to follow those tasks, remember what am I supposed to do next. Planning and organizing for individuals, being able to think out and plan ahead and then be able to follow through and complete it. They are easily overwhelmed, become anxious and stressed with too much information again. So looking at a pile of papers, expecting them to put them together and organize them or plan out their day, it's too overwhelming for them. It's too many steps, too much information for them to be able to process. Transitioning can be from going from one task to another or even just one thought to another. So getting up and leaving the house for school, that transition, leaving the house, getting on the bus, getting off the bus, going into school, those changes are quick and abrupt. The brain is working way too fast to be able to process, understand what the next step is. So when they're on the bus, they're going to school, but now we're here and now I have to go into school and now I have to follow a routine. Very overwhelming for them. And if it's an abrupt transition, if they expect and are have been told they're going to a birthday party on Saturday, and all of a sudden that party is canceled. Every single day they were being reminded of that party they were going to, and then all of a sudden it's canceled. A transition like that, an abrupt transition, can cause them again to feel anxious, overwhelmed. And because they're unable to understand their own feelings, that's when we may see those behaviors. Impulse control, very impulsive. They see it, they think it, they have to say it, or they see it, they want it, and they take it. They're impulsive, they're unable to control those thoughts and prepare for what's ahead. Well, if I run out into the road to grab my ball, I'm not thinking I have to look both ways. A car could be coming, I could be hit by a car, I could cause an accident. They're not able to process that information the way we are. So for them, it's just they do it. And then afterwards, some cases, individuals are able to understand, but at that moment, that thought process of planning ahead is just so impulsive, they just do it. Emotional control, unable to understand their own emotions and self-regulate. They can be very moody just because of something somebody says, or they're uncomfortable in a situation, so they have mood swings, or they become aggressive, angry, and sometimes they even shut down. Attention and focus, very easily distracted, and they can be very easily distracted according to sensory issues. If the temperature's too hot, if it's too cold, lights are too bright, they're very easily distracted on what's going on around them. So whatever the environment looks like depends, it has an effect on how much they're paying attention and how much they stay focused on that specific task.
No, I think you did a good job.
Okay. Adapt functioning, cause and effect. This is one of the areas that causes a lot of parents, educators, and even service providers a lot of stress. An individual with an FASD, it is very difficult for them to be able to link cause and effect. If I take that candy bar without paying it, I'm going to get in trouble. For some of us, it's a very simple concept. Don't take it if it doesn't belong to you. If you go out and you're not allowed out, you're going to get in trouble. If you don't hand in your homework, if you fight in class. For these individuals, linking that cause and effect is very difficult. So they're going to repeat the same thing over and over again, causing frustration to everyone around them. Consequence and reward systems, again, unable to make that linking connection, they don't work. Abstract concepts. Individuals with FASD, very concrete and literal thinkers. Time and money. Math is one of the subjects that these individuals struggle with the most because it's very abstract. I've had family members say, well, they're doing very well in math, so they can't have an FASD. That very well may be, but as they get up into the higher grades and they start having problem solving examples and learning, that's where the issue they're going to have, because they have to read it, and being able to problem solve is already an area of impairment for them. They're not able to follow through with all of those steps. So math, very abstract, telling time. These are individuals that are either always late for class, missing appointments, late for work, because they just don't grasp that sense of time. I'll see you in 5. What does that mean?
So just to touch base on the cause and effect, this is where if we're not understanding where the individual's symptoms or behaviors are coming from, then we're not providing the appropriate intervention. So with FASD, their symptoms are showing us that they don't have the ability to connect the consequence to the behavior. So in behavioral health settings, most of our interventions is behavior modification. Behavior modification is typically ineffective for kids with an FASD because they're not able to make that connection. But because we're not seeing as a provider the response we're expecting, then they are then viewed as just being purposefully manipulative, acting out, defiant, because we just are missing the boat. We're not understanding why they're having these symptoms. It seems like they're doing it on purpose, when that is not true.
We go back to abstract concept of money. Individuals with an FASD, they have the money, they spend the money. They're not planning ahead. They have bills, they have rent. They just have the money in the hand and they want to spend, or they go and try to buy things that cost more than the amount that they have. So money for them is a very abstract, difficult concept. Social skills. These individuals have such a strong need to belong and fit in. They want to have friends. However, they don't really understand social cues and they struggle with maintaining and starting relationships. These are individuals that have no boundaries. They have no understanding of boundaries. So they're overly friendly, very affectionate, and think everyone is their friend. For the younger kids and even for the teenagers, stranger danger is a very big concern because to them, anyone who smiles at them, anyone that says hello to them, that is their friend and they will go off with them. So having them understand that this is a stranger is a difficult concept for them because to them, everybody is their friend and because they have that need to fit in and belong. These are individuals that are targeted by others who find them and see their gullibility and can get them to do things that the individual would have never thought of doing on their own. This could give them issues with the law. It gets them in trouble and expelled in school because they will never tell on that individual. And if they're being interrogated, if this is a legal matter, they not only want to fit in and be accepted by the individual who may have set them up to do something illegal, but whoever is interviewing them and questioning them. It's just like a parent questioning them why they acted up in school. Their first instinct is to not want to disappoint. So their reaction would be, I don't know. To most parents, that's very frustrating because you should know. Problem solving skills, again, not being able to follow through, understand there is a problem, come up with solutions to solve the problem, and then being able to physically do that, comply with that solution. So problem solving skills for them is very difficult. They can't think ahead, nor can they connect their behaviors to causing a problem. So if it was something they chose to say or do and they did it, they have trouble making that connection that my behavior caused this problem. Sensory, hyposensitive and hypersensitive. These individuals are very sensory. They can either have a very high tolerance for pain, which is the majority of the children that I work with. They have a very high tolerance for pain. They can have issues with sound. They can have issues with bright lights. And even the slightest sound that not many of us can hear, they can hear. Touch is another big thing. These are kids that don't want to be touched or children that need that tighter squeeze. We've seen that some kids, it's almost like they look for reasons to get restrained or to have that hold because that type of pressure is comforting to them. Anything else? No. Affect and emotional regulation, being able to identify their emotions. These individuals struggle with self-regulation. They are not able to say, the sounds in this room are bothering me, it's making me angry. So what tends to happen is these individuals act out. You see the behaviors. To them, their behaviors are their form of communication. I use the example with families. If you have a child coming from another country, an exchange student, you don't know their language, they don't know yours. How else are you going to communicate with them? It's a struggle. Same thing with an individual with an FASD. If they are not able to identify why they are feeling and what they are feeling, how can we communicate with them? Because their only way is through their behaviors. So then we get to the meltdowns. Individuals who are overwhelmed, stressed, angry, fearful, even excited, they may have a meltdown. It may be their way of reacting. They may either become aggressive, they may become withdrawn and freeze, or they may be a flight risk and they may be those individuals that need to run.
So an area of the brain that's impaired is the amygdala, and that's the area that's responsible for the fight, flight, or freeze response. So being that that is a very sensitive, it's an impaired area of their brain, it is easily triggered. So for us typically to experience their fight, flight, or freeze response, it has to be something pretty traumatic, pretty huge. For kids with an FASD, it's something very minor. It might be I accidentally brushed their shoulder, or I said something in a tone that was alarming to them. Something very minor causes this big, huge explosion, that meltdown. We see this a lot in crisis, where a child was brought into crisis for a crisis assessment because they had a major meltdown at home, and they, caused some property destruction. Maybe they got physically aggressive. Maybe they eloped, had the typical fight, fight, or flees response. But when they were able to calm down, once it's over, it's over. And if we go back to cause and effect, they're not making a connection why everybody is upset. Why is mom dragging me to crisis? Why do I have to go to the hospital and talk to these people? There's no connection there. So when we do our crisis assessment, typically the outcome is there's no lethality. This was just a behavioral response. That is always a big red flag to me, that this could be something that we're looking as an individual impacted with an FASD, especially when the child does not really understand why they're coming there and why everybody is upset.
Motor skills, fine and gross motor skills. These are individuals that lack coordination. They struggle with the finest of things, that they have to handwriting, scissors, playing catch, riding a scooter. These are also individuals that may need to get up and get out of their seat and roam around. But to the teacher individual, it looks as though they're being very disrespectful. But for them, they have to get moving. They have to get up. Some of them, for walking, taking long walks, jumping, fidgets, they need that. Not being able to recognize that it's helping them to self-soothe, but they need to do these things in order to calm themselves down. We also look at joint weakness. Some individuals who are constantly falling out of their chair, again, not being able to sit upright or sit still very long. There's a disconnect within their core muscles. So it's almost like those messages that are going to the brain kind of stop at the core. So these individuals, again, unaware, not being able to explain what's going on, they can't sit still, they can't sit upright, and their muscles start to weaken, so they have to get up and move around. I also just wanted to go over processing of information, which is very big for individuals with FASD. It takes an individual with an FASD 22 seconds to process one sentence. So sometimes in giving them tasks or going over directions or even discussing why they just behaved a certain way, we could be talking to them and it almost looks as if they are looking through us. They've shut down, or you may see a behavior. For them, too much information, too much talking at a time where their brain is not only trying to understand and process what they're saying, what the individual is saying, but trying to process everything around them, following their senses, the sight, the sound, the temperature. So for them, too much information will cause them to shut down. That's why we want to stay with very short, to the point, and the least amount of task and direction.
Yeah, the phrase is there are 22-second kids living in a 2-second world. So we are instant. We want instant responses. So when we don't get that instant response, that's when we start viewing them as being willfully, purposefully acting out, defiant, stubborn. So it's not understanding where these behaviors are coming from. So what you see is not what you get. With FASD, the terminology that we use instead of immaturity is actually dysmaturity. When we say a child or an adolescent is acting immature, that gives us the belief that they have the ability to become mature. And with FASD, it's not age, it's stage. So we see dysmaturity, meaning that's kind of where they're stuck. That's where the maturity level is for that skill set that you're seeing. So with this picture, the actual age is an individual who is 18. And again, in the video, it said FASD is the invisible disability. So you can't see it. This individual has expressive language that could come off as either 18 or sometimes much older, like a 22-year-old. With FASD, their expressive language is not impaired. It's the receptive language that is impaired. So their understanding is much more limited than what they're expressing. So we're viewing this individual as a normal 18-year-old. They're talking very mature. They must understand. They look completely normal. There's no issues. But really, their reading ability might be more of a 16-year-old, but their comprehension is like a 6-year-old. So it's like half their age. So they could read out loud in class, but they're not comprehending what they're reading. So that comes to a lot of problems academically when the teacher is viewing this student as a typical 18-year-old. They're reading out loud just fine. Why are they, having such a problem on comprehension tests? Especially when we don't understand that this is coming from a brain-based issue. Their living skills could be more like an 11-year-old. Again, remember they struggle with abstract, so money and time concepts, more like an 8-year-old. And their social skills, again, is like half their age. So their social skills and their social maturity is like a 6 or 7-year-old. So when you have a typical looking 18-year-old adolescent, female or male, who has that goal ability and that strong desire to get along with others and be connected socially, but their social maturity and their social skills are half their age, you can only imagine what kind of trouble that could find them, with boys and with girls. But with girls especially, we see a lot of concerns for human trafficking. These are kids that are very prone to get themselves into sex trafficking and not even understand that this situation that they're getting into is wrong. We see a lot of adolescents being attracted to joining gangs because, again, they have that desire to be socially connected, but they don't have that awareness that this situation they're walking into is potentially dangerous.
I think one of the other things is the group of children that they hang around with or that they interact with. For some 13-year-old who looks just like a 13-year-old, they may relate better to smaller kids. Or you might hear a parent say, well, they are so good with babies and smaller kids. I think it's often looked at as odd and strange, but to them it's not. And when approached and questioned, the child may react with the behavior because that's who they feel comfortable with. We also have to understand that individuals with an FASD, especially children, they know that something's wrong. They know and feel different. And they sense that. So I think a lot of times they can feel that discomfort before we even realize there's something for them to be uncomfortable about.
Yeah, one of the examples I like to use to really kind of showcase the difference between their actual age and their social maturity is at one time we had a group home, and we had an adolescent who assessed positive for probable FASD. And she was, I would say, like 15, 16, and loved to play with baby dolls. And that was where her social maturity was. That was just, she loved her baby dolls. So we didn't shame her for that or try to say, no, you're 16, you need to act your age and play with something more age appropriate. Instead, we taught her how to play with her baby dolls in a socially appropriate way. So bringing her baby dolls into the living room with all the other 16-year-old adolescents, she was going to get made fun of, and she was going to get bullied. So we allowed her to have time in her room and have her like a nice, cute setup so that she could play with her baby dolls when she had time in her room. So it's really about understanding what stage we're seeing, again, not age, what stage we're seeing and providing appropriate interventions for that stage that does not involve any kind of shaming or expecting them to be able to mature. Because again, it's that word dysmaturity. So now we have our secondary challenges. So when we're not understanding where the behavior's symptoms are coming from, then we're not providing the appropriate fit of environment, meaning that we're not providing appropriate interventions. So when a child is in preschool, a lot of the social skills are, very young anyway, so you're not able to really see anything that's alarming. When they go into kindergarten, that's where kids really start seeing and feeling that their brain works differently. They start, learning some basic academics that maybe they feel that they're having a harder time comprehending than their peers. Then they go into first grade, and then they really start seeing that their friends are maybe moving on or grasping skills much quicker, differently than they are. And again, they have that dysmaturity. They don't have the language skills to express what they're really feeling. So we start seeing behaviors. We start seeing the symptoms. And we as providers and school systems and parents, we respond to those behaviors as we would for a typically behaviorally acting out child. So we're just exacerbating their feeling that there's something different about them, there's something wrong with them. So this just continues the older that they get. Then we start placing them in behavioral settings. They start having SBBH, they go to foster care, they're inappropriately hospitalized. They go to partial hospitalization. So we keep putting these individuals that are struggling with a brain damage in behavioral settings that is not appropriate because we're not understanding where the symptoms are coming from. So our interventions are not helping them. So we're just helping kind of create this sense of internal self that there's something wrong, that they must just be a bad kid because that's the way that the society is responding to them. So when they come into our services, we're treating the secondary challenges. So we're treating the mental health issues that come about because of that, substance use and addiction, the legal issues. There's a lot of school suspensions for these students because, again, teachers do not understand why these students are struggling in the areas that they're struggling in. As they get older, they don't have that ability to save money. They're very impulsive. So we see a lot of homelessness, a lot of evictions. They very much struggle with appropriate friendships and safe relationships. They have inappropriate sexual behaviors, and they grow up and they have parents. So a lot of the times when we see parents struggling to parent their child the way we assume they should be parenting, we also kind of label them as being non-invested in their child's treatment. They're always late to appointments, they're missing appointments. So they seem like they're not wanting to be a part of, their child's treatment when then themselves might be impacted with an FASD and have the same challenges that we went through with the symptoms. There's a misperception that they're intentionally, being manipulative and they're acting out on purpose. And most kids with FASD are overlooked.
So what do? We want to build on their strengths. It's very important to understand that individuals with an FASD, behind all of those negative, aggressive, acting out behaviors, they truly have some amazing strengths. They have creativity, they are athletic, and they are caring. I must say that for the children that I have the pleasure of working with, every one of them truly is very helpful. They are generous and they are willing to help. They can be persistent, but we can always turn that into a negative, and determined as well. So the general principle of interventions is providing support for the family. Having that education and helping families to understand their child is not intentionally behaving this way. Their child does not enjoy making them angry or acting the way they do. Providing an answer by giving them education and understanding what fetal alcohol spectrum disorder is. Supporting the family and helping them through those difficult moments, but to come out and find ways to help them deal with those challenging behaviors, but most importantly, for them to understand their child. Collaborating and partnering with the family, not just the family, but with services. I feel it's very important, whether it's a mobile therapist, an outpatient therapist, whoever is involved in treating the family should work as a team. Constant communication and collaborating discussions should be mandatory. It should be, because one person that is not involved in what just took place at school on Tuesday, and they see them the following week, it causes more overwhelming and stress for the family when everyone is not on the same page. Providing education to our schools, having the teachers, the staff, and anybody working with them in the school, helping them to have a better understanding. Help the child and the family function efficiently. It's all about understanding and eliminating not just the stigma of FASD, but that the child is not a bad child.
So one of the first interventions that we do at Children's Service Center once they have a positive life history assessment, which would indicate a probable FASD, is we do a comprehensive strengths assessment for the child, but is also for the parents, to really start pulling apart what are the strengths in the whole family unit, in the community, who are services that are connected with this child, what are their strengths, but really focusing all our interventions back on the child and the family's strengths. These kids, like I had said, they really start developing this identity that there's something wrong with them. And we reinforce that by providing inappropriate behavior modification interventions that are ineffective. So everyone around them is just getting frustrated. So these kids just kind of grow up with this sense of identity that there's something wrong with me. So they develop very poor self-esteem, oftentimes end up with diagnoses such as intermittent explosive disorder, oppositional defiant disorder, and then, ultimately conduct disorder. So by reinforcing everything that we're doing, kind of focusing back on the individual strengths as well as the family strengths, is helping to change that mindset. We really educate parents that they need to be spending, at least 5, at minimum 10 minutes a day doing a positive activity with their child, despite what was going on that day. That kids need to feel that unconditional positive regard all the time, especially from their caregivers. And, kids with FASD are very challenging. They're probably one of the toughest kids to parent, because kids with an FASD are consistently inconsistent. So every day is different. Every day there's a new struggle. Sometimes they remember things really well and they're doing great. And other days their brains are overwhelmed and tired and exhausted. And so they struggle with things. So they're very, very difficult. So helping the families really understand where these symptoms are coming from, that this isn't on purpose, and spending that positive time can make all the difference with these kids. Yes.
So here are the 8 magic keys, and this is kind of what we follow. We want to talk in concrete terms, avoid abstract language.
Can I say something to that? So one of the programs that we have here is Wellness Court, which is like treatment court for adolescents. And as you can imagine, multiple kids that come through our Wellness Court program have assessed positive for a probable FASD. And our judge that we utilize in this county for the kids does a phenomenal job working with the youth. She's very caring and compassionate, but she has not yet, from my understanding, been FASD informed. And she spends a lot of time with each individual, and she asks them, if they're understanding, if they're feeling okay, but she uses a lot of abstract words. And it's so interesting to hear the kids' response after court. So of course they're nervous, they're intimidated, they're in front of a judge, but the judge will use the terminology almost with every kid that she's going to give you a window of time. And they always, after court, they ask their peer, what does that mean, a window of time? Like, they just do not understand it. And then every court, I'm like picking up more and more abstract terminology that she is saying. The other court hearing, she had mentioned things are snowballing. And again, that youth at the end of court was she had no idea what the judge was even referring to.
Consistency. Parents and educators need to use the same words and strategies. This can be very confusing because The way we look at it, we cannot cure FASD, we cannot cure or fix brain damage because that's what it is. However, we can make accommodations and modifications to help an individual. So I've had children say, Mom's voice is annoying. I can't stand to hear her. And then they're getting punished and they're getting in trouble because mom's upset. She feels disrespected. But by using the same words, it can be a tone, the tone in which somebody says something, how they say it, their body language, and the environment that we're in. So parents, and again, this is not allowing an individual with an FASD to get away with something, but we have to change the way we look at a consequence or punishment. It's not about punitive where we have to take something away. They need to be punished. So all of these things need to be taken away from them. We have to change that thinking to redirecting and reteaching. A consequence for an individual with an FASD should be redirecting and reteaching. So if there isn't a consequence that needs to be implemented, the educator, the parent, whoever is implementing that consequence, it should be stated the same way and using the same strategy. These individuals, they need consistency, repetition, KISS, keep it short and sweet. You can't give them more than 3 directions, 3 tasks. Pick up the books, put them on the shelf, clean up the floor, get the broom. You can't give them too many because by the time you get to the second one, they're already stressed and overwhelmed because they're forgetting. We have to keep it short and sweet. Stop running. Stop hitting. And stating something as clean room, well, that's an abstract concept because what does clean room really mean? It can mean many of things. To us, we know what cleaning the room is. It's go in and clean your room. But to these individuals, you need to be specific. No more than 3 tasks. And you're going to repeat things over and over again. A routine. This helps to reduce their anxiety. These individuals need to have a specific, consistent routine. You will even notice some individuals that the minute that their routine is broken or it's not followed, you can start to see the behaviors. You can see them triggered or that anxiety. They need that specific, consistent routine. Structure, that's the glue that makes everything stick together for them. Supervision, they're always going to need some sort of support and supervision. To what extent? That depends on their support system and how they're able to understand and process whatever it is that you are trying to help them with. And the master key is trusting relationships. It's very important for these individuals to have a support person. I see a lot of children that don't have a support system, whether it's family or even at school. One person, a trusting person that understands FASD, understand how that individual thinks and exactly where they need that support can make a difference. Changing the environment. So again, it's not about changing the individual. We're looking at changing their environment and not just the room that they're in at the moment. Each area, it could be one classroom, oh, they're just going to the next room. But that next room, that environment is completely different. The color of the room could be different. The teacher is different. The way the seating is. We have to look at the environment, and it's a very big help on what's going on with the individual. If the room is too loud, if there's too many kids, if the lighting is bad, or if the work itself, if the individual is given work to do and they already feel overwhelmed because they know they can't do it, you will see a behavior. Providing them with supervision and low stimulation, we're looking at less things, less decor, not a noisy environment, and then structure, consistency, and predictability.
So the low stimulation, this is really important when we're working with families with kids with an FASD, their sleep patterns. They have a very hard time falling asleep and staying asleep. And one of the sleep hygiene things that we teach is their bedroom should be very simplistic. There should not be a lot of stuff on the walls. Even the pattern of their bed sheets should be just a flat color. They obviously should not have any like gaming systems or access to using their phone when it's time for bed. Being mindful of the lighting, just all sensory, because kids really do struggle with their sleep. One of the key differences between FASD and ADHD is kids with an FASD, they have a hard time falling asleep. Once they fall asleep, they typically wake up often throughout the night. So another red flag would be parents that say, you know, I find my child playing video games downstairs at 3 o'clock in the morning, or going into the refrigerator to get food in the middle of the night. And how am I supposed to do my, go to work during the day when I need to be up all night monitoring them? That should be a big red flag that we're probably looking at a kid that's impacted with FASD. Their sleep patterns are about 15 minutes. So they typically don't go in that deep REM sleep, which affects their memory, because that's when your short-term memory gets into your long-term memory. So that's another area that why they struggle with their long-term memory. So kids with an ADHD, they typically have a hard time falling asleep, but once they're asleep, they usually stay asleep, and then they have a hard time getting up in the morning. Where FASD, hard time falling asleep, up frequently at night, and then they're easy to get up in the morning.
Changing expectation. I think this is the area that is very hard for not only just the families, but any adults working with the individual. We look at them, we look at their chronological age, they should know better. They know this. Our expectations need to change. We need to lower our expectations and meet the individual where they're at. So we need to stop saying that they won't do something. Instead, ask ourselves, is it that they can't do it? Do they need help with it? What kind of support do they need? I think that is the biggest thing for parents. They struggle with, oh, they know better. They know to clean their room. They know they shouldn't talk back. They know they shouldn't behave like that. That's our expectation, but that may not be where the individual is at. So we really need to focus on asking ourselves again, is it that they won't do it or they can't do it? And then changing and lowering our expectation of that individual. Keep in mind developmental age, not chronological age. Interdependence, not independence.
So this is a big one for interdependence that, we always focus on becoming independent. We want our youth to really learn all the skills to be independent. But honestly, no one is independent. We are all interdependent. We are all interdependent on each other, on our coworkers, on our family members. There's nothing truly that we do that is independent. So it's very important when we work with kids with an FASD that we're modeling the interdependence. One of the examples one of the FASD trainers used was a youth was refusing to take their medication. And the trainer was coaching families to say things like, well, I take medication too, even if it's a vitamin, and have them buy in, because remember, they really want to be helpful for you, and that relationship is key. So saying to the youth, I really have a hard time remembering when I need to take my medication. So do you think you could remind me and I'll remind you, and we could take it at the same time? So you're really demonstrating that interdependence, that we always rely on each other to do, any task. And the example I always use is our FASD education. Like, I am interdependent on Jessica, that I don't like doing these trainings alone because she is the true expert in these areas. So I really rely on her. So we're interdependent on each other for these trainings even. So really focusing on changing, not using independent and using the terminology interdependent.
And that is something I hear a lot from families. Well, what's going to happen when they get older? They need to be independent. And that is true. But again, what is it that you're looking at? They're going by their expectations, what they want for that child. And I've seen some children that, again, very hands-on. These are very visual learners. They learn best by having it role modeling, having something shown to them, and then having them do it. So I say to parents, skills, life skills, anything hands-on, they are learning, and they're learning at their ability. You have to lower your expectations. I think the other key point is acceptance, accepting that the child does think differently and that they need that extra support. But I also remind parents and children that we all need support in some way, and our brains all work differently. It's just some people need a little bit more support than others. Applying strategies and interventions, being proactive, repetition, and building on the strengths. I know as a parent myself, it's very difficult when you have a child who has just had a very aggressive or destructive meltdown. You can't sit there and want to praise them for it, but it's very important that we find a way to praise and remind these individuals just how important, creative, strong, helpful, whatever their strengths are, and point that out to them. It's important. That positive praise is really important because most of these individuals and a lot of the kids that I work with, even as young as 6 years old, they have a very low self-esteem. Just some facts for how FASD has affected Pennsylvania. There are estimated 1,164 children born with FASD in Pennsylvania each year. According to Dr. Larry Bird, approximately 37,278 children are within the child serving systems. So that's our mental health services, foster care, adoption. The task force was established in 2007, and FASD costs 30 times more than the cost of successful prevention efforts.
Do you want to touch on the Respect Act?
Sure. So we have the FASD Respect Act. It is still on the floor. Hopefully it will get a little further than it did last year. But the Respect Act will help not only bring education and awareness to fetal alcohol spectrum disorder, but it will help acknowledge it as an intellectual disability. It will provide for more funding and research and services.
So FASD has been a term since the 70s, and it's kind of fluctuated with funding. So some years throughout history, there's been more funding than others. I believe that there was a Pennsylvania Center for Excellence at one time that Dan Dabowski worked at. He was our initial trainer. He is a true FASD expert, and they were doing amazing work and making a lot of progress, and then they lost their funding. So if the Respect Act goes through, then that funding will then come again, and there'll be a lot more opportunities to really bring this knowledge and expertise, hopefully, to all counties across Pennsylvania. So here is just some materials for you, some resources. There's a list of websites that Jessica and I find very helpful, some podcasts that have great information. I don't know if you had anything.
The first, one of my favorite websites is the FASD and Me, because it has grown over the past 2 years, but it's an interactive. And if you take a look at it, especially where it has kind of like a little story of what FASD is for a child, I paid very close attention to just the way the speed. It's not very fast, it's not too slow, but you can see that the creator is allowing time to process. There's a lot of interactive games. I have a couple of kids I work with that have had fun on it. They like the games and great information. And again, it's continuing to grow. So it is a great source, especially for children who are aware of FASD.
And then there's the FASD project. There's a link to that video. The second video on this is another phenomenal. There's actually a 2-part. Unfortunately, the third video, that link is not working. I think it's a private maybe a paid video that Jessica had. So that link is not going to work, unfortunately. Sorry. There's some books.
So we have Trying Differently Rather Than Harder. It's Diane Malbin, fantastic book. It's not a very large, thick book, but it gets right to the point and great resource of information. Making Sense of the Madness is by Jeff Noble. It's a survival guide. It's funny. He makes light of things, but he gets to the point too. And I think you'll find support and comfort with that, especially with some of the stories in it. Again, the book that goes with that is his FASD Sound Bites Insanity Savers. And The Animals in My Brain is a favorite of ours. It was written by Sarah Joseph. It's a great book utilizing animals and discussing the changes in our brain.
It's a great tool to work with, to read to children. I've read it in our partial hospitalization in the kindergarten and primary classrooms. It's a great tool to help kids understand how their brain works differently and why. And the animals are absolutely adorable. So it's a great tool to have. And some more resources.
We're going to end with another quote. This is by a child with an FASD. FASD doesn't heal with time. Love people for who they are and not for who you want them to be. That's where the disconnection starts.
Thank you, Summer and Jessica. I'm always amazed. Allison and I are sitting here and we were just talking about, we love listening to you ladies speak, and it just always makes me think of how many youth I've come across over the years that I'm questioning, like misdiagnosed. How many kids with the autism diagnosis, the more when you sit back and you think about it, I'm like, is it really autism? I know the last year when we had you speak, we also went into that conversation of kids in residential. When we have kids that maybe aren't responding well to residential, that we are questioning, could they actually have FASD? So I thought that was very interesting to hear that as well. We will open it up for questions, and just to let everyone know,
I think you're muted, Jen.
Whoop, sorry. You will get an email with the PowerPoints and also a medication sheet that Summer and Jessica sent us. That's very wonderful. And you will also get the links for the pre-test, post-test, and evaluation. So they will be coming to you for an email as well. So we're going to open up for questions if anybody has any. Okay. Laura, you have your hand up. If you want to go ahead, I'll let you go ahead and unmute yourself. Try it again, Laura. Laura, can you hear us? It's not letting you unmute. Okay. If you want to try to go ahead and put your question in the chat, Matt, I don't know if you're able to see if you're able to unmute Laura by any chance.
Yeah, can you raise your hand again, Laura? I can find you in the list. Thank you.
Matt is our wonderful IT, so he's on with us for technical issues like this.
Okay, try it now.
Go ahead, Laura. I don't think it's letting her still, Matt. So
sadly, sorry.
Nope, that's okay. Laura, looks like she's going to log out and log back in. We'll come back. Laura, if that does not work, you could go ahead and just leave your message in the chat. Does anybody else have any other questions while we're waiting for Laura to come back?
So while people are thinking about their questions, one of the things, I was talking about kids being in residential and maybe not responding well to that treatment. For any of the services that we work with youth, that's one of our kind of big red flags, is if a child has multiple mental health diagnoses, also been tried on multiple different psychotropic medications, and we're just not seeing them respond to the way that we would hope them to respond. But then our clinical intervention, if it's not effective, even if it's family-based, school-based, partial, residential, if we're not being effective, to start thinking like, well, maybe we should view this behavior differently and think brain-based, even if we don't have the tools or abilities to do an FASD assessment, just to think that maybe this is brain-based. And the example I use a lot is we had an adolescent in our older classroom, and she had failed out of every school system that she had ever been in and was about to fail out of our school system as well, because she was being so disruptive and just wasn't gaining anything from it. So I really kind of took a look at her and I thought, this kid is very sensory. She is responding to everything very sensory, which was appearing to be behavioral, acting out in the classroom. And she didn't assess positive for an FASD, but I asked the classroom to just change interventions to address the sensory, because she would say, I can see sound. That's how much it impacted her. And just providing a few tweaks in the classroom, and kind of pulling her desk out so she could still see the teacher, giving her noise canceling headphones. Those interventions completely changed her experience, and she ended the year very successful, passed all of her classes, and formed great relationships with her teachers. And that was the first time in her academic career that that ever happened. So just instead of, us punitive her and saying like, well, you're just acting out, you're just being disruptive, this is another classroom that you're going to fail out of, changing our modifications, whether or not we have even the assessment in front of us that this could be FASD, just start thinking about behaviors differently.
Thank you, Summer. And I do see Laura's back. Laura, can you hear us? I'm going to see if I could allow your mic, Laura. So Laura, I don't know if it's letting you unmute, but again, you could put in the chat if you want your question, and we'll be able to answer it that way too. Summer, your contact information, is it okay to give them your contact?
Yes.
You want email or just phone number given? Because I could send that out to the group too.
Email and phone is fine. Yep, for both of us.
So,
and if anybody has any questions, feel free to email either one of us. And, we love to do community outreach. If there's another opportunity that somebody wants, some education, we are very open to spreading the word.
And they are wonderful to work with. So again, if your organization, school, anyone is interested in something similar, please reach out to them. Or if you have questions regarding anything, they're both wonderful to work with, and we'll be able to direct you in the right direction. We will have this on the CMSU YouTube page as well. So if you need to come back, something happened where you got a phone call or something, we know how it is. Please feel free to go back on the YouTube channel to review it.
And then it looks like the question was posted in the Q&A section. It says, what are some tests that you use to assess kids for FASD?
So we use Dan Dabowski's screen and assessment tool. So we partnered with Dan. He was part of our initial pilot project where he came in and did education for all of Children's Service Centers clinicians. So he educated us on his screening tool, which is like a 5-question screening tool that we do at intake. If that tool, and those are kind of the red flags I've been referencing. So there are some pretty hardcore criteria that once you get familiar with working with kids with an FASD, you're going to just pick up very quickly. So that's really that initial screening tool. And then if that's positive, they do a life history assessment. So the screening tool and the assessment, we're not able to share because Dan really wants to provide his initial education to system partners that want to utilize his screening tool. So if you are ever interested in working with Dan, he is phenomenal to work with. He does initial coaching calls. He really makes sure that you're feeling very comfortable with using the screening tools and are aware of the strategies to implement when you do kind of partner and contract with him. So I could share his information if anybody is interested.
That would be great, Summer, if you can. If you want to send it to me in an email, I could even send it in that email chain for anyone in case they do want it.
And he is local. He lives in Philadelphia, so he's easily accessible.
So it looks like Laura put in here, it says, I understand that you stop once you know you're pregnant and don't drink if you're planning for a kid. But what are the recommendations for women since alcohol affects women before they know that they're positive of pregnancy? And if 50% are unplanned pregnancies?
Yeah, that's where the education of prevention really is super important, because we are a society of individuals that consume alcohol. It's a very normal part of our daily life. You know, every activity, there's typically, even in the video at the bridal shower, they're celebrating with champagne. It's a very normal part of our society. So it is just important that we're educating. It really struck me, my daughter is in college now, but when I started this project, she was a senior in high school. And so, of course, you know, I mean, once you get into FASD, that's all you talk about. Can annoy your family. But my daughter was like mind blown, because she remembers, just as I do in high school, like in health class, you know, in 5th grade, you get a, you know, 1-day kind of blurb on this is FASD, and it focuses on the facial features. So she had no idea. And it really is that college aged group. You know, there was one training we went to and they said, this is not a socioeconomic, you know, issue. This is typically college-aged, you know, women that are drinking and have access to it. And, you know, we get pregnant. I mean, I was 21 years old when I got pregnant. So it's really just being aware that, you know, even if you are sexually active, that you could get pregnant, that alcohol couldn't impact, you know, your pregnancy. There's a couple states, or a state, Midwest.
In Minnesota, that has pregnancy tests in the restroom.
At bars.
At bars.
So you could actually take a pregnancy test before you start drinking for the night. You know, it's just being that aware. But also in hand, there's a lot of protective factors. So, you know, I don't like to scare people that you had, you know, a couple drinks and you didn't know you were pregnant, and, you know, you found out, you know, 4 to 8 weeks later. There's a lot of protective factors as well. You know, if you are in a safe relationship, if you're taking care of, you know, prenatally, if you know, you don't have food insecurity, you know, those are all things that exacerbate, you know, if you are experiencing those, the impact of the alcohol exposure as well.
And we do have one more last part of her question is, could you clarify the comment you made about positive praise despite a meltdown? Do you mean praise during or outside the meltdown?
So when a child is experiencing a meltdown, that's that cortisol release. There is nothing that you can do in that moment. You cannot regulate a dysregulated brain. You need to wait for that to for their brain to calm down. So it's not praising the meltdown. It's making sure we don't keep bringing that up. So doing that re-education of, you know, what could we have done differently when we were feeling this emotion? We have some families that bring their child into crisis and they just want to keep rehashing, yeah, but he broke the window. And then the next day meeting with Jessica, did you know my son broke the window? Like, just constantly needing to go back to that moment. You're just re-escalating that unnecessarily. So really focusing on what could we have done differently, and highlighting the, you know, the situations when they did make a different choice, and really praising those situations.
Like if they just had a meltdown and they've calmed down, praise them for that. I'm glad you were able to calm down. Focus on that as the positive, that they've calmed down, instead of going back to what led to that, you know, and even addressing it. You don't, once the child has calmed down and everything is fine, you don't want to bring that up. You know, I always say use those as talking points when everything is calm. And it's best not to put the child or use the child as an example. Parents will start to use themselves. Something like, I was at work today and my coworker, she said something and it made me like this. You know, showing the child that as an adult, I can feel angry, because you want them to have that visual. But putting them back into that example or discussion as it was them who did something is only going to reignite, because right there, the way they're perceiving it and the way they're hearing it is, I'm a bad kid, it's my fault, and I did this, I'm wrong. You know, we also have to understand that their perception, a lot of times the way that something is said, they perceive it the opposite. No is a very big trigger. For them, they hear and understand the word no as go away, I don't want you. So that can end up being a trigger. Simply advising parents, well, use a different word, or offering the choices. That's always a good option.
Thank you so much, and very good questions. So I appreciate you asking them. I know we're a few minutes over, and again, you will get an email with the pre-test, the post-test and evaluations, also the PowerPoints, and a medication sheet that Summer and Jessica gave us as well. If anybody doesn't have any other questions, we will adjourn for the meeting, for the webinar today. And again, Summer and Jessica, it's always nice working with you ladies. We appreciate you bringing this knowledge over to the Columbia Montour Snyder side. And Allison is our prevention specialist supervisor here at CMSU. So a lot of times she focuses around bringing information to the community around prevention services. So if you have any other questions regarding drug and alcohol services as well, through the Columbia Montour Snyder, you're welcome to reach out to her as well. Summer, Jessica, anything else you could think of before we let you ladies go?
I don't think so. If we start talking on a subject, we're just going to keep you here all day. So.
We love it. We plan to make this an annual thing with you ladies.
Yeah,
so
absolutely.
We appreciate
we love that.
Well, thank you so much again. And Matt, thanks for helping with the technical issues. So we appreciate it.
My pleasure.
Thanks. Take care,
Thank you.
everyone. Bye.
Bye.